MLE-style question. A 65-year-old man with a history of hypertension and hyperlipidemia presents to the emergency department with sudden onset shortness of breath and profound hypotension. He had an anterior wall myocardial infarction, MI, 5 days ago and was discharged home on aspirin, beta blockers, statins, and ACE inhibitors. On examination, he is diaphoretic and in severe respiratory distress. His blood pressure is 70/40 mmHg, heart rate is 110 BPM, and respiratory rate is 28 breaths per minute. On auscultation, there is a new holosystolic murmur best heard at the left sternal border. Pulmonary examination reveals bilateral rales. Which of the following is the most likely cause of this patient's condition? A. Ventricular free wall rupture. B. Papillary muscle rupture. C. Interventricular septal rupture. D. Acute pericarditis. E. Recurrent myocardial infarction. Answer and explanation. Correct answer. C. Interventricular septal rupture. This patient presents with cardiogenic shock, hypotension, pulmonary congestion, tachycardia, and a new holosystolic murmur after a recent anterior MI, suggesting an interventricular septal rupture. Timing occurs 3 to 5 days post-MI due to macrophage-mediated myocardial degradation. Murmur, a harsh holosystolic murmur at the left sternal border, often associated with a palpable thrill. Hemodynamics, left to right shunting leads to volume overload, heart failure, and shock. Echocardiography with Doppler confirms the septal defect. Management, emergent surgical repair and supportive care with vasopressors and afterload reduction. Why not the other options? A. Ventricular free wall rupture typically presents with sudden cardiac tamponade, muffled heart sounds, jugular venous distension, hypotension, pulseless electrical activity without a murmur. B. Papillary muscle rupture, more common with inferior MIS, leading to acute mitral regurgitation, severe pulmonary edema, cardiogenic shock, murmur at apex. D. Acute pericarditis, occurs 2 to 4 days post-MI. Dressler syndrome occurs later. With splenic chest pain relieved by leaning forward. No murmur or shock. E. Recurrent MI. Can cause chest pain and ECG changes, but does not explain the new murmur and acute hemodynamic collapse. Would you like another question with a different focus?